Over the next hour, live from Trinity Mother Frances Vascular Institute in Tyler, Texas, see the treatment of an abdominal aortic aneurysm. Rupture of an abdominal aneurysm causes profuse bleeding and leads to shock. Patients who undergo the endovascular treatment for the repair of AAA typically find fewer side effects and have a faster recovery than the conventional open surgery.
We've changed a procedure that typically required 2 to 3 days of intensive care unit stay and up to a week of hospital stay into essentially a 23-hour admission to the hospital and home the next day, and back to full activities within a week or two.
During the procedure, you can email your questions right to the OR by clicking the M-Direct Access button at any time. Now let's go live to the OR.
Welcome to Trinity Mother Frances Hospital in Tyler, Texas. This evening we will be performing an endovascular abdominal aortic aneurysm repair utilizing the Gore excluder endoprosthesis. I'm Dr. Todd Smith, and I'm joined here with my partner Dr. Kent Webb, and we'll be the moderators for this evening's case.
Some of our guests tonight may wonder, what is an aneurysm? An aneurysm is an enlargement or ballooning out of any artery in the body. The most common artery in the body is the aorta, which is the large blood vessels that arises from the heart, goes down through the chest and the abdomen. 90% of aneurysms arise in the lower part of the aorta, below the level of the arteries that go to the kidneys. Aneurysms can be very dangerous because they are prone to rupture or burst. If this happens, it can lead to catastrophic complications such as bleeding and death. In fact, 80% of patients with ruptured aneurysms will die before they reach the hospital. So recognition of an aneurysm and diagnosis of an aneurysm is very important so we can get these patients treated before they have the chance to rupture. Aneurysms have been surgically repaired since the 1950s. The original repair was not very effective, but it involved a large incision in the abdomen where the surgeon would wrap some material around the aneurysm, typically cellophane, to keep it from rupturing. Albert Einstein actually had this repair, but he ended up dying of a ruptured aneurysm later. After that, surgeons began to replace the aorta with an artificial or synthetic graft, a tube made out of Dacron material. This operation was very effective in treating aneurysms and preventing them from rupturing. However, it is a major operation requiring a very large abdominal incision and prolonged time in the hospital to get over the procedure. And Todd, you can tell us about a new minimally invasive treatment that's been developed.
Well, this technology really began in the early 1990s with Dr. Juan Perotti in Argentina, who performed the first endovascular abdominal aortic aneurysm repair. And since that time, this technique has become the treatment of choice for most patients with abdominal aortic aneurysms. As Kent mentioned, this technique, as opposed to the open aneurysm repair, allows for patients to be treated with less morbidity and mortality, a shorter hospital stay, and a shorter recovery time. And this evening, this is the procedure we will be seeing. During the presentation, if you have any questions, feel free to click the button on your screen, and we'll answer any questions that you may have. At this point, we're going to go in the operating room and join our partner, Dr. Todd Bingston, who is performing the aneurysm repair.
Two Benson guide wires. And good evening. Tonight we're repairing an abdominal aortic aneurysm with an endovascular repair. This gentleman's a very pleasant 77-year-old gentleman. He's got a history of coronary disease and some asthma, and he's had an aneurysm for some period of time that has grown, and on a recent study was approximately 5.3 centimeters in size. And we evaluated him with an ultrasound initially, and then a CT scan, and subsequently an arteriogram. These are just imaging tests to allow us to know how to repair the aneurysm. And this gentleman was a good candidate to have an endovascular aneurysm repair or a minimally invasive aneurysm repair. And that's what we're going to do tonight. We've been working for about 10 minutes so far, and what we've done is we've made incisions over this patient's groin areas, over both femoral arteries, the arteries in the legs, And so far we've exposed those arteries and put a small plastic tube or a sheath in those arteries. And the sheath or the tube that we have in the arteries now is very small. We will upsize that to a much larger sheath when we get ready to place the device. But right now we're going to get some guide wires up in the aorta and start to get some pictures of the aneurysm and associated arteries around the aneurysm. Can somebody move this mic to my mouth, please? Is that better? Okay, fluoro, please. Move that up a little bit. Gabe, you're in my way. Fluoro. And so now we are, fluoro, live. We are guiding a wire up the right femoral artery, and that's in the aorta now. We'll get ready and guide a wire up the left side. Fluoro. And there it goes. Go on up a little towards the head.
At this point, you see the fluoroscopic images
Right.
with the guide wires being advanced in the abdominal aorta.
A pigtail catheter on the left side. Left side. And we've given 5,000 a heparin.
And Todd's inserting a pigtail catheter, which is a diagnostic catheter, which we put some contrast or dye through into the aneurysm to take some accurate measurements before the graft's deployed.
Come on up towards the head.
You can see the pigtail catheter being inserted. The pigtail catheter has marks every centimeter to help us take measurements within the aneurysm.
And so we have our pigtail catheter in place. We're going to get ready and attach it to the dye injector, and we'll get ready and take some pictures here in a second. And come forward on the dye, please.
At this point, an angiogram will be performed with
And
marking
back,
of the renal arteries. It's obviously important that the graft be placed below the renal arteries, and that's a critical part of the procedure. And so that's something that we'll be looking for on this angiogram.
Some viewers may wonder why it's important to place the graft below the renal arteries. Can you tell them a little bit about that, Todd?
Well, clearly we wouldn't want to cover the renal arteries as far as perfusion of the kidney arteries go. Another important part as far as the preoperative planning of this type of operation is to make sure that there's plenty of aortic neck below the kidney arteries in order to attach the stent.
Nice. It shows that good, Peter.
And at the top of the screen, you can see both the arteries going to the right and left kidney arising.
Look at this arteriogram and document where the renal arteries are, which are an important landmark. And we're going to be able to count exactly how long of a stent we're going to want to use here.
At this point, you can see both the renal arteries. Again, it looks like the aneurysm neck has a length of somewhere between 2 and 3 centimeters, which would be adequate for proximal fixation of the endograft.
All righty. Let's have a Benson wire, please.
The neck of the aneurysm is the area of normal aorta below the kidney arteries before the aneurysm arises, and it's important to have an adequate neck.
Now we're exchanging our wire out for a very stiff wire
in order to seat the stent properly below the kidney arteries to seal off the aneurysm.
Fluoro. Good. Off. Okay. We have a multi-purpose to my side, please.
Now, Kent, we talked that this aneurysm was about 5.5 centimeters, as Dr. Bingston mentioned. On this angiogram, it doesn't look quite that big. Can you explain to the viewers why we don't see it quite as well here?
Well, what we're actually seeing is just the lumen or the inside of the aneurysm. There is usually a layer of plaque or thrombus, which is hardening of the arteries, and some debris or atheromatous debris, which generally can be anywhere from 1/2 to a couple centimeters thick around the inside wall of the aneurysm. The dye column, when the dye is injected, it actually just fills the very inner part of this. So the actual dye image will be smaller than the actual diameter of the outer wall of the aneurysm.
And I think that emphasizes why arteriography is not a very good test looking to size aneurysms, and an ultrasound or a CAT scan is a much better way to look at that.
But we do use the arteriogram for once we've decided to place a graft. It's very important in terms of measuring the length of the aneurysm to accurately place the graft.
Stent graft through here. But you can see the difference in the size in this sheath versus the sheath that we're getting ready to pull out and replace. You off there? Okay. Got wire? Hold that sheath up to this one. So again, we're replacing sheaths, and our initial sheath was a diagnostic sheath, 7 French, and now we're placing an 18 French sheath. All right. And this sheath's going to come right on in. Flora?
The sheath that's being put in now is the sheath that the device will actually be delivered through here in a few minutes.
Okay. Hit saline, please. Stop. Where? Where's your...
Barely. This one cuts in and out. We got it.
And we'll just inject some heparinized saline.
That's better.
Okay. We've got the device ready. Let's load the device. And this is a 2616 main body and its lateral limb. So here's our actual device, and the actual stent graft is here. It's on a plastic shaft that will allow us to get it into the aorta at the correct position. On the back side of the shaft, we have a pull knob that will allow us to deploy it exactly where we want it to be deployed.
Do a demonstration.
We can drop his mean pressure to about 65.
At this point, we have the endoprosthesis outside the body here. We can show you how it's deployed.
And
Kent here is going to go ahead and deploy that device.
Getting ready to enter our sheath. And just come right on in here. And are we going to gate on that side? Looks good. I'm going to go on and unsheath it.
Dr. Bengtson has the device now up into the aorta.
Floral, let me bring this back a little.
And he's pulled the sheath back to allow deployment of the
I
graft.
think that's good right there. Let's do another.
If you can zoom the camera in on here, we can show you a little bit what he's doing.
We're going to get ready now and do a final arteriogram before we deploy our device. And
here's where
the renal arteries are. And that's what we're getting ready to do.
Here's where we are. At this point, the device is outside of the sheath. In order to deploy the device, as Kent will show, you would pull this knob, which will allow expansion of the graft in the aorta.
Hold respiration.
And you can see right here as the graft expands on this end here. There we go.
So now we're watching fluoro and marking exactly where the renal arteries are.
The graft would be expanding like this.
Fluoro, please. Bring our pigtail down. Going to bring our device down.
And the completed graft looks like this. It's actually a stent, a series of stents with graft material on that, which is hollow inside, and it has 2 limbs that go down to each iliac artery running to the legs.
I think Dr. Bingston's now deploying the graft.
This is a modular 2-piece graft.
And you can see the graft in place here, right at the kidney arteries, which is the renal arteries, which is where we want it.
At this point on the fluoroscope, you see the main body has been deployed below the level of the renal arteries. You can see the contralateral gate, which is opened up and appears as a ring-like structure at the bottom of the screen. That will ultimately be cannulated, and the contralateral limb will be placed through this. At this point, cannulation of the contralateral gate will be performed using a floppy guide wire and a multi-purpose catheter.
Okay, here's our aortic balloon. We're going to inflate the aortic balloon here. This is our proximal attachment site. Secure that gate. Fluoro. And this secures the graft there at the renal arteries. And we'll do 2 inflations here. Stop. Fluoro. Okay, fluoro. Okay, we need to adjust my mic.
We can show here what Todd's doing.
Let me adjust my mic up. I mean, it's
Todd has the ipsilateral limb. If you can
You
zoom
put it
in
on
on
my
this, I
lips.
don't know if you're able to
Is
do
that it?
that, but that can...
Okay, can you hear me now? Is that better? So the device is in place. We've secured it there at the proximal attachment site, and we're going to get ready now and try to access the gate so we can get the other leg in. And fluoro. Yeah, bring that out carefully. All right, let me have a multi-purpose catheter, please.
Here we are now with a floppy guide
Stop.
wire and a multi-purpose catheter for cannulation of the contralateral gate.
And what we're going to do now is try to access the little gate there. You see a round opaque marking, about 3/4 of the way down the screen. And I've got to get a wire in that and get a sheath in there. And so we use an angled catheter to direct our wire there.
Todd's trying to get that guide wire to go through that ring, or the gate, what we call the gate. And it can be sometimes difficult because you're seeing it in only one projection, but you're working in 3 dimensions. He's using an angled catheter to guide the wire up inside that gate. At times, cannulation of that gate can be difficult, and additional catheters, either reverse curve catheters or catheters with more acute angles, can be used for successful cannulation of the gate.
You want to oblique it a little bit?
Dr. Bingston, when you're having trouble
cannulating the right angle catheter.
when you're having trouble cannulating
Yes,
the contralateral gate, do you have any tips that you can use to help with that?
Well, I think several tips are multiple angled catheters. The catheter we just had, a multi-purpose catheter, has a very gentle angle on it. We're going to load up a comfy catheter, which has a more acute angle. Sometimes not just the angle of the catheter, but actually where the catheter is in the aneurysm sac will make a difference. So if you bring the catheter back and use more wire or less wire, sometimes will work. And then if we can't get it with this catheter, we can snare a wire over the top of the junction. So this just really requires some patience here. I thought we were in there, but we weren't. We're just back.
So what Todd's trying to do is to get a wire to go through this gate,
you want to oblique it,
through the other side. You can zoom in on that. That can be somewhat difficult because sometimes the wire wants to come in at a different angle.
And we've changed the angle of our fluoroscopy now to hopefully let us visualize it better and get it where it needs to be. But so far, not wanting to go in there.
At this point, again, we're trying cannulation of the contralateral gate. Dr. Bingston has obliqued the fluoroscopy, trying to get a little bit better idea of
Peter,
the
I don't like that oblique's not helping us that much.
The orientation of the gate to attempt a cannulation. Dr. Bingston, let's say that you can't cannulate the contralateral gate from this approach. What do you do then?
If we can't get the gate cannulated from here, we'll come from the right side and snare a wire and come across that way. And that's not a problem at all. It's a little more tedious, but generally we'll get a wire up in here. It may just take us a second.
Todd Smith, we have some questions that have been submitted by our online audience. The first question, who would you say is at risk for an aneurysm? Well, in general, if you look, aneurysms are more prevalent in males, about 5 times more prevalent in males than females. There's also
a different angle catheter. That one's not doing it.
An increasing incidence with age, with the highest incidence being after age 60. General risk factors would include things like smoking, diabetes, family history of an aortic aneurysm. So in general, those are patients who would be at risk. And also, I think hypertension plays a role too.
Sure,
as well. How would a person know that they had an aneurysm? Well, most aneurysms are asymptomatic. A lot of aneurysms are found as an incidental finding, either for some sort of other complaint, getting an X-ray or an ultrasound. Symptoms specific of an aneurysm are classically abdominal pain or back pain. And so some patients will come in with that, although most of the patients we see are asymptomatic and have an aneurysm discovered on another type of imaging modality.
Another question is, what limitations does the stent graft have with regard to tortuosity? And for our audience, tortuosity is the curving of the arteries, which can sometimes play a role in our factors for determining what type of procedure to perform. Can you explain a little bit about that?
You know, tortuosity comes into play in two different areas. It comes into play in the infrarenal neck, which affects your proximal fixation, and it also comes into play in the iliac arteries, which has more to do with your ability to actually advance the device and sheaths through the iliac arteries. Now, typically we can get a stiff wire up through the iliac arteries and straighten those out. So most of the time that does not preclude endovascular repair. With severe angulation of the proximal neck, there can be some issues with fixation proximally and maybe an exclusion in some patients which would prevent them from having this type of repair.
Another question is approach to the femoral artery. How do we get these catheters in the femoral artery?
We do open exposure of the femoral arteries, and this is performed through oblique incision. These are performed through oblique incisions in the groin just below the inguinal ligament. This can be done with a percutaneous fashion in some cases, but routinely we do bilateral femoral cut downs,
which are just really very small incisions over the arteries, which in most cases would be a safer approach to the artery to prevent complications at the insertion site.
Absolutely. And with future improvement in the devices, we may ultimately have a percutaneous method which we can fix these aneurysms.
Most patients, we should tell our audience that in the past, when patients had to have an open aneurysm repair with a large abdominal incision, those patients would usually be in the office or in the hospital up to a week, and sometimes spending 1 or 2 days in the ICU. Nowadays, with this procedure, most patients can go to a regular hospital room within an hour of the procedure, spending a short time in the recovery room, and then generally an overnight stay and home the next day. So.
Yeah, most patients are up and around the next day and are discharged that next day, postoperative day number 1, and within a couple of weeks are back at their preoperative level of functioning. So it's quite an improvement when you look at the rate of complications, the hospital stay, and the recovery time compared with open aneurysm repair. Again, at this point, Dr. Bingston is working on cannulating the contralateral gate. This will ultimately allow deployment of the contralateral limb of the graft, which we'll be seeing here shortly.
We can demonstrate this on the model here. Todd has the, if you can turn, there we go. Todd has the gate cannulated with our model here, and the catheter is loaded, or the stent graft is loaded on the catheter, and I will deploy it by pulling the string here, which then opens the stent, and the stent is seated in the other side of the graft here.
And at this point, we see what the completed device would look like. It's been called a pair of pants, but essentially you have an ipsilateral limb and a contralateral limb that are both deployed into the iliac arteries.
This particular device is made by the W.L. Gore Corporation, called an excluder, because it excludes the blood flow from going into the aneurysm, thereby preventing the aneurysm from expanding and preventing rupture. It's very effective in that regard. It's important to note, though, that patients that do have these endovascular procedures do need to be followed up in the office and have testing generally every 6 months or so after the procedure to make sure the graft still remains seated correctly and to make sure the aneurysm does not continue to expand.
Yeah, and that is one important distinction from open abdominal aortic aneurysm repair, where follow-up is not quite as stringent for the patients and time requiring. So that is something that we like to discuss prior to the surgery, just to make sure patients understand that lifelong follow-up really is an important part of this procedure. At this point, you can see Dr. Bingston's using a different shaped catheter. This is a reverse curve catheter, which should facilitate cannulation of that contralateral gate. I think this just goes to show you that you have to have a pretty broad array of catheters and guide wires in these type of cases so that the wire doesn't just slide right up into that contralateral gate. You do have some options and different alternative ways to cannulate that gate.
So what we're going to do on this cannulation is we're going to come across from the other side and use a snare to grab the wire. Okay, hold that. Okay, let's have a snare over here. Let's bring this out. Yeah, Floral?
It's required probably in about 1 out of every 10 cases, 1 out of every 15 cases maybe.
Yeah, it's something that we see in a technique that we use, not in the majority of cases. An alternative technique, if this wasn't successful, is to come through a brachial artery approach from the arm and bring a guide wire from above. And that's used probably less often than this technique that we see here.
Just the catheter. Yeah. Pull it out of there. Yep. And just load that on the wire, the white thing.
At this point, a snare will be advanced up that contralateral side, and the wire will actually be caught with that snare and pulled down into that contralateral artery, which will ultimately allow cannulation of that contralateral gate.
Another question submitted, Todd, was how are most patients diagnosed with aneurysms? I would say in my practice, most patients that are diagnosed with aneurysms don't really even know they had an aneurysm.
Yeah, and that's true. As we talked about, most aneurysms these days are found as an incidental finding. Patients are having ultrasounds and CAT scans and all sorts of x-rays for various conditions, and on those an incidental aneurysm is found quite often. So some patients will present with symptoms, but most of them present asymptomatically as an incidental finding, and a rare number of patients will present with a ruptured aneurysm.
And that's an important distinction, Todd, because most patients will not have any symptoms until their aneurysm ruptures. And that's why we feel that screening programs are important with ultrasound, that patients with some of these risk factors like smoking, high blood pressure, diabetes, family history of aneurysm, it's important for them to have a screening ultrasound of their abdomen and look at the aorta, because that's a non-invasive test that can be performed in the physician's office or outpatient setting that can easily diagnose the presence of an aneurysm.
Absolutely, and with this minimally invasive treatment like we're seeing this evening, if we identify aneurysms early and can get them fixed with this type of operation, obviously that'd be much better for the patients. Patients who present with a ruptured aneurysm have a very low chance of survival. So we'd like to identify and treat as many of these aneurysms as we can before that event happens.
We have treated some of these patients that have had ruptured aneurysms with the endovascular graft, and that has really made a big difference in their survival.
Yeah, in a select group of patients that have a ruptured aneurysm, either a ruptured iliac aneurysm or a ruptured aortic aneurysm, this may be an option for repair in those patients. Again, we've seen that it does have some benefits related to survival of these patients, as well as hospital stay and recovery. So when it is available, it is a good option for those patients as well.
You can see that Todd is feeding a wire down toward the snare at this point.
Yeah, I can put it, but it just goes sideways. See where it goes?
Well, again, at this point, patience is really what is required. As you see on the screen, you're seeing a two-dimensional picture of this snare and guide wire moving, when in reality these are moving in 3 dimensions. And so some patience and a little bit of time is usually what is required in order to get this wire snared and continue with the procedure. Again, if this was not possible to snare this wire, another option would be coming from above and cannulating that contralateral gate from above through a brachial artery approach.
And for our audience, a snare is essentially just a wire basket which can be tightened around the wire or catheter, and then that wire can be pulled down into the proper position. You can see on the screen, the X-ray screen there, the wire basket that now is being tightened down, and he has snared the guide wire. Then the guide wire will be pulled into proper position.
So we access the gate. There we go. Okay.
And that's a successful snaring right there.
Good. All right, let go, Gabe. Okay, back yours out. No, you need to let go.
And again, what this demonstrates is that at times you'll need a vast array of catheters and guide wires, and need to acquire the skills necessary to perform these types of maneuvers like Dr. Bingston's just shown us.
And that's why most of these procedures are performed in centers that are experienced with these types of techniques and have all the equipment available.
Comment on what? Yes, we've just gotten the contralateral gate accessed. And make that even up. Our initial attempt in the usual way that we do that, just in accessing that gate from below with multiple catheters, was unsuccessful. So we placed a catheter over the top of the graft, and then we're able to snare that with the snare. And then after snaring the wire, we're able to pull our catheter up into the gate. So we don't have to do that very often, but it's a nice way of getting the gate access when you can't access it from below. So we're going to get ready and replace sheaths here and place our contralateral limb in just a minute. Yeah, let me have the pigtail catheter placed. Do we need to get length here or not? Oh, do we need to get length? And we'll take some hand dye in a minute.
Now that the contralateral gate has been cannulated, pigtail catheter will be advancing the main body of the graft. We like to spin that catheter in the main body of the graft just to confirm that we do actually have the catheter and guide wire positioned within the main body of the graft. At times it can be deceptive, and the wire and catheter can be placed either in front of or behind the main body of the graft, and you would not want to deploy that contralateral limb in that position. Here's Dr. Webb demonstrating how the catheter is going up into the main body of the graft and how you can spin that catheter.
And this will be an arteriogram to look at our internal iliac artery on the right side. Go. And that's important because we don't want our stent to extend any farther than this internal iliac artery. So we'll measure the distance now.
That's the artery that branches down there that you can see.
And we'll get ready and replace sheaths now to place this contralateral device.
Well, the distance is measured on this catheter, as you see, with those markers, which are 1 centimeter apart.
This is stiff, super stiff. Good. Line it up.
This will provide us a guide for the measurement of the contralateral limb, again, making sure not to cover the internal iliac artery.
And get the 18 ready. And we're just counting our distance to where we want to be. 5, 6, 7, 10. I think that'll be good.
And again, here's this pigtail catheter, and as Dr. Webb's pointing out, there are marks along this catheter that are 1 centimeter apart. This will allow you to gauge the length of graft needed in this case.
Right. About where? That'll be fine. Okay, and the larger sheath, please. And we're going to get ready and replace the small sheath with the larger sheath. And on the artery where that sheath came out, we can just pinch that with our finger and prevent it from bleeding much as we place the larger dilator, which is what we're doing now. Fluoro. And we'll watch that go up. You can see that on fluoroscopy. And it'll go right through that gate that we had such difficulty accessing. It's in good position now. Stop fluoro.
Well, Kent, we have another question here, and somebody has asked what determines whether a patient is a candidate for an open versus an endovascular repair.
That determines, a lot of factors go into that determination. We like to try to do every patient with an endovascular repair because we feel it's easier on the patient. However, certain factors such as the length of the neck or normal aorta below the kidney arteries are important because
and take a picture and see if we're finished.
We need enough normal aorta below the kidney arteries in order to seat the stent. So if an aneurysm extends all the way up to the kidney arteries, those patients usually are not going to be candidates for an endovascular procedure because the stent would have to cover the kidney arteries and shut off the blood supply to the kidneys.
And real quickly, somebody asked what size must an aneurysm be before insurance will cover the procedure?
That probably varies from region to region. Our patients normally, in general, we use about 5 centimeters as a cutoff. Most patients, after 5 centimeters, the risk of rupture of an aneurysm starts to increase dramatically. And so in most patients, around 5 centimeters is where we would recommend repair of the aneurysm. That's not to say we don't fix smaller aneurysms. Say you have a patient with a 4.5 centimeter aneurysm, but it's expanded rapidly within the past year. That patient you might recommend endovascular aneurysm repair in that type of patient.
Here we see now the contralateral limb being advanced over the guide wire. It'll be advanced into the contralateral gate and deployed.
So this is the contralateral limb of the device. Again, it's on the plastic tubing that will allow me to place it where it needs to be in the gate. And this graft fits through this sheath, and it's all placed over a wire, which you can see here. Fluoro. Now we'll watch fluoroscopy and we'll watch the graft go on up. All the way? Okay, you've got a problem.
Here we see the contralateral limb now in the contralateral gate. The sheath is being pulled back so that limb can be deployed into the iliac artery. Again, markings have been made of the internal iliac artery to be sure not to cover that artery with the stent.
Yeah, okay. Is that gone?
One last question, Kent, concerns the number of endovascular aneurysms performed in this area. Do you have an idea of what that might be?
I'd say that probably in the Tyler area we've performed about probably 120 to 150 procedures per year in this area. So it's a procedure that is very common. In fact, probably in the United States, there's 1.5 million people that probably have aneurysms. Most of those are not diagnosed. 200,000 probably are diagnosed in the United States. It's again, as we said, it's the 13th leading cause of death, and in fact, over 15,000 people died from a ruptured aneurysm in the United States last year. So it's important to diagnose this early and to treat it when it becomes appropriate for treatment. Now, how do we decide who to treat? In general,
we're going to place our angioplasty balloons within the graft, and those will secure the attachment site between the limb and the main body, and then they will also iron out both limbs in the iliac arteries. So we'll just get ready and place our angioplasty balloons where we need them and expand them.
And while Todd's putting the catheters up,
there we go. Come on up with yours, Gabe. Flora?
The bottom line is that we would recommend an operation and repair of an aneurysm when the risk of the operation becomes less than the risk of rupture. And in most patients, that's around when the aneurysm is about 5 centimeters.
I think clearly this technique has become our procedure of choice for treating aortic aneurysms in our patient population. And compared to 5 or 10 years ago, the numbers have significantly increased.
The attachment site of our contralateral limb and main body, and you can see our angioplasty balloons expand, and that's just going to secure that joint very well so that it will seal. Okay, come down. Stop, Floral. And just a touch of Floral. Yep.
We'll do a couple of more inflations along that graft just to iron out both of the limbs, and then do a completion arteriogram to show what hopefully will be the final result.
It looks like things are going along well right now.
Okay, up.
Well, I mean, a successful procedure will be determined based on the angiogram. We'll look for several things, both the location of the stent in relation to the renal arteries proximally, and distally in relation to the hypogastric arteries. We'll look for leaks, specifically a type 1 endoleak, which would be at either a proximal or a distal fixation site, or what's called a type 2 endoleak, which is typically a retrograde endoleak.
And Todd, what is an endoleak for our viewing audience?
Well, and the principle of the procedure is basically excluding blood from the aneurysm sac, blood and blood pressure primarily. An endoleak is some type of leak that allows pressurization of the aneurysm sac. There are multiple types of endoleaks, and some are more important than others and need to be addressed sooner than others. A type 1 endoleak, again, would be at the proximal or distal fixation site, and typically we don't leave the operating room if that type endoleak exists. Type 2, 3, and 4 endoleaks are less worrisome and usually can be followed more conservatively.
It's important to realize, too, that endoleaks can develop later on, long after the procedure. As the aneurysm sac starts to shrink down, that can change the configuration of the graft and cause it to shorten or elongate. And there have been instances where the attach points of the stent have come loose at one point and allowed leakage into the aneurysm.
And this is why surveillance afterwards with ultrasounds, CAT scans, plain films of the abdomen are critically important in this subset of patients.
Back up. So we've the main body of the device is placed. The contralateral limb has been placed, and so the device is as we would have it and completely in, and it's been ironed out and secured with the balloon dilations. And we're going to get ready and take an arteriogram, and again look to see that the device is in the proper placement in relation to the kidney arteries and also the internal iliac arteries in the leg. And we will make sure that the device is widely patent, those arteries are widely open, and that there is no leak around the device. Floral.
An endoleak, if there were to be one, would be seen on the arteriogram here. It'd be seen as contrast that leaked into the aneurysm sac.
Essentially what you're saying is it would leak outside the graft or somehow enter the aneurysm sac.
Correct. It'd either leak around the graft or come through some other channel, typically in a retrograde fashion through a lumbar artery or possibly a patent inferior mesenteric artery.
And those are smaller arteries that sometimes will feed into the aneurysm and allow back bleeding into the aneurysm.
Here we have a pigtail catheter that's positioned at the level of the renal arteries just above the endograft, and we're getting set up to do our final arteriogram.
Months or even years after the procedure, sometimes the endoleaks can develop, and they would usually be diagnosed with CT scan or ultrasound, which can be performed in an outpatient setting.
Laurel? There we go. Okay. I'll let you call it and we'll be ready.
If an endoleak occurs, it usually can be fixed with minimally invasive techniques and does not usually require open surgery.
Stop. Looks good, Peter. So that was our final arteriogram. At the top, you can see the kidney arteries are still open and working nicely. The device is directly below the kidney arteries. There is no leak. There's no blood flow in the aneurysm sac at this time. So the aneurysm has been excluded. The actual device is widely open and the blood is flowing through it nicely. And then down at the bottom of the picture, the two iliac arteries are open and working nicely. So the device is in place. The aneurysm is repaired. It doesn't look like there are any problems with it at this point. And what we'll do now is we'll really just convert to open surgery and remove these sheaths and repair the small holes in the top of the arteries that these sheaths make. Okay, you can come out.
Kent, there's one final question I thought I would address here. Someone's asked if there's a genetic factor that would make someone more prone to developing an aneurysm.
Yes, there is. In fact, that we do find that aneurysms tend to run in families, and if a patient does have an aneurysm and they have a first-degree relative, such as a brother or sister, they should certainly be screened for aneurysms. Okay. And there is a increased risk of a brother of a patient that has an aneurysm, the brother would also have an aneurysm. Interestingly, though, if a female has an aneurysm, if that patient has brothers, they are at much higher risk of having an aneurysm than if a brother has an aneurysm, a male to male. So female siblings, her brothers would carry a much higher risk of having an aneurysm.
Correct.
But we would recommend that all family members over the age of 50 be screened with ultrasound of their abdomen. If they have a first-degree relative, brother, sister, mother, father, that has an aneurysm.
And we have one final question here. It says, can the excluder main body be passed through either the right or the left femoral artery? And the answer to that is yes. We usually make a determination preoperatively based on the size of the artery, calcification, tortuosity, which artery would be best to pass the the main body through. So that can be done either through the left or right femoral artery, and that's typically the surgeon's preference based on those criteria that I mentioned.
Okay, it looks like Todd and Gabe, his assistant, are closing the small incisions. And generally, this is a closure of the tiny incisions just requires a few minutes of operating time, and then the patient will awaken from anesthesia and go to the recovery room.
Well, on behalf of my partners in Trinity Mother Frances Hospital here in Tyler, Texas, we'd like to thank you for joining us for this live webcast of an endovascular aortic abdominal aneurysm repair. As you can see, this is a very effective technique for fixing abdominal aortic aneurysms and requires a large amount of skill and sometimes some improvisation of the surgeon in order to get this done successfully. Again, there are a large number of people that's required to do this successfully. We have a very good group of anesthesiologists, circulating nurses, scrub techs, all of who play a critical part in the successful performance of these type of procedures. Again, we thank you for joining us this evening, and good night.
You have just seen the treatment of an abdominal aortic aneurysm performed from Trinity Mother Frances Vascular Institute in Tyler, Texas. To obtain more information, to make an appointment, or make a referral, please click the appropriate buttons on your screen.